Hi everyone, today we'll talk about amoebic liver abscess. It is caused by Entamoeba histolytica, most commonly seen in males in the ratio of 10:1. Higher risk of infection seen in heavy alcohol consumption, immunosuppression and malnutrition. Coming to the pathogenesis, humans are the principal host. The spread is via the fecal-oral route, that is followed by the ingestion of the cyst. The cyst hatches in the small bowel, releasing trophozoites, which is carried on to the colon, forming flask-shaped ulcers in the submucosa. The trophozoites multiply and form cysts, and these cysts are passed in the feces, and the trophozoites enters the liver via the portal vein. They get trapped in interlobular veins, which multiply in the portal triads and causing focal infarction of the hepatocytes and liquefactive necrosis, which ultimately leads in abscess formation. 80% of the abscess are found in right lobe of the liver, giving an anchovy sauce appearance. It is generally odorless. Only exception is if it gets secondarily infected, it can be foul smelling. Glissen's capsule is resistant to the hydrolysis, and abscess usually abets the liver capsule. Amoeboma is mainly due to chronic infection in the large bowel, leads to granulomatous lesion, and that is known as amoeboma. It usually presents with fever, right iliac fossa mass, and blood-stained mucoid diarrhea. The most important differential diagnosis is colonic malignancy, and colonoscopy is done to rule out malignancy. Clinical features: it is seen in young males in the age of 20 to 40 years with a history of travel to endemic areas, presenting with fever, chills, anorexia, right upper quadrant pain with tender hepatomegaly. Jaundice can be present if the abscess cavity is pressing on the biliary tree. The right shoulder pain is due to irritation of the diaphragm. It can rupture into peritoneum, resulting in peritonitis. It can rarely rupture into pleural and pericardial space, resulting in pleural and pericardial effusion. Investigations: there is increased total leukocyte count without eosinophilia, unlike any protozoal infection. There is anemia, increased PTINR, and LFT shows mild derangements. Colonoscopy shows exudate covered ulcers with normal areas in between, mainly affecting the cecum and the ascending colon. When you aspirate, the aspirate is sent to for culture. The culture comes negative, and microscopy will not show any leukocytes. Radiological investigation: X-ray shows elevated right diaphragm. USG abdomen shows rounded lesion abutting the liver capsule. It's hypoechoic and non-homogeneous. CT scan differentiates from pyogenic abscess, where pyogenic abscess demonstrates rim enhancement. Treatment: metronidazole 750 mg thrice daily for 10 days. Others can be secnidazole and tinidazole. Luminal agents to destroy trophozoites in the large bowel, that is diloxanate furoate, iodoquinone, paromomycin. Pigtail insertion under USG guidance for larger abscess and high risk of rupture. Peritoneal rupture needs laparotomy, peritoneal lavage and drain placement. In case of large bowel, there can be severe hemorrhage and toxic megacolon, which is a very rare complication. We need to resuscitate the patient. Laparotomy has to be done, and resection of the affected bowel, and followed by loop ileostomy until the anastomosis heals. Thank you.